Thanks for coming. Without any further discussion of the baseball game, Inyoung Lee, we're not related, is here today to give us our seminar. Inyoung has a BS in pharmacy from Ewha Women's University in Seoul, an MS in pharmaceutics from Seoul National University, and then spent time at IMS Health in Korea before she joined us here as a PhD student in PSOP. She's currently a second-year PhD student and is going to be talking to us today about some work that we're doing together in COPD patients.
Yep.
All right, Inyoung, it's all yours.
Thank you. So this is the slides I traded off with watching Cubs game yesterday. My analysis is not final. It's in the preliminary stage. I was doing analysis up to yesterday, so I just wanted to, as a disclaimer, that this is a preliminary results. And today I'm going to be talking about risk of cardiovascular events in Roflumilast users with COPD. So this is the outline of today. I'm going to be talking about background and then move on to method section, talk about the results and some of the limitations and future steps. So Roflumilast, the exposure of interest in my study, goes by the trade name of Daliresp in the United States. It was approved in March of 2011. So it's a relatively new drug, and it's the first and only PDE4 inhibitor approved for COPD. So it's not a bronchodilator and should not be used for relief of acute bronchospasm. So the indication for this drug is treatment to reduce the risk of COPD exacerbations in patients with severe COPD associated with chronic bronchitis and a history of exacerbations. So this is aimed for mainly prevention of further exacerbation, which is associated with significant increased risk of mortality. So the mechanism of action is PDE4 is the major PDE isoform in airway smooth muscle cells and inflammatory cells. And PDE4 prevents, so the role of PDE4 enzyme is that it breaks down the cyclic AMP into AMP. So by inhibiting the PDE4, it prevents the breakdown of cyclic AMP. So it increases intracellular cyclic AMP level inside the lung cells. This leads to relaxation of smooth muscle cells and decreased activity of inflammatory cells and mediators. So in the heart, PDE inhibitors increase heart rate and contractility by inhibiting breakdown of CAMP. So following this mechanism, positive inotropes PDE inhibitors have been used as positive inotropes in chronic heart failures. And because it increases heart rate and contractility, it has side effects, cardiovascular side effects such as arrhythmia. And previously, PDE3 among the PDE isoforms was considered to be the major isoform responsible for majority of activity in the heart. But there has been increasing evidence that PDE4 may also play a role. So which leads to the question whether PDE4 inhibitor will also have any cardiovascular adverse events. In the 8 controlled COPD studies, the reported adverse reactions were diarrhea, weight loss, nausea, headache, back pain, influenza, insomnia, dizziness, decreased appetite. So no major cardiovascular adverse events were reported, but there were conflicting findings about cardiovascular safety in Roflumilast users among studies. So this is a research question. is the use of Roflumilast in COPD patients associated with the risk of cardiovascular events compared to those on non-Roflumilast therapy. So following the PCOTS format, the patients was identified as COPD patients following the indication for Roflumilast, those with severe COPD, aged 40 and above. Intervention, so our exposure cohort was Roflumilast initiators, and our control cohort was those on combination of long-acting beta agonist, long-acting anticholinergic, and inhaled corticosteroids. And outcome was first hospitalization due to acute MI or ischemic stroke or arrhythmia. And the time I looked at was through May 2010 to December 2013 for those covered in Truven Health database. So the study design was retrospective cohort study, and the data source was Truven Health database, which has individual level database that covers clinical utilization, expenditures, and enrollment across inpatient, outpatient, prescription drug, and carve-out services. It has data from approximately 350 payers and has two parts to it, so commercial claims and encounters database and Medicare supplemental database, and I utilize both of them. So this was the study timeline. So the index date was defined as initiation of Roflumilast or control medication. The index date was defined between May 2011 through June 2013. This was because even though Roflumilast was approved in March of 2011, when I looked through the database, the first prescription occurred in May 2011, so I restricted the time to that. And by restricting to June 2013, I allowed at the minimum of 6 months of follow-up. And looking back from the index date, I had 1 year of baseline period where I confirmed that they did not use Roflumilast or control medication, and I ascertained continuous enrollment through that period. And then from the index date onward, there was a follow-up period until either outcome or disenrollment or medication discontinuation or end of study period. So the total study period was between May 2010 to December 2013. So my study cohort, the inclusion criteria was that they had to have incident prescription of Roflumilast or control medications, which I defined as combination of ICS, inhaled corticosteroids, plus LABA, long-acting beta agonists, and LAMA, long-acting anticholinergics. And they had to have COPD diagnosis. So they had to have at least one inpatient or two outpatient diagnoses within the baseline period. And at the index date, they had to be aged 40 or above. So exclusion criteria was patients who had used Roflumilast or the combination medication during the baseline 1 year prior to index date period, and patients who had less than 1 year continuous enrollment prior to the index date. So how I identified the control cohort, which I identified as the combination of inhaled corticosteroid, ICS, plus LABA and LAMA, we basically looked at, referred to the GOLD guideline, the Global Initiative for Chronic Obstructive Lung Disease guideline. And so this table shows you the ABCD goes down with increasing severity. So patients in group D would be the most severe COPD patients. And we can see that PDE4 inhibitor is aimed for really severe patients and comes later on in patient group C or D. So we could guess that those were severe COPD patients. And so we try to select a control cohort that had similar COPD severity by referring to this table. And if you take out all the regimen that has PDE4 inhibitor, then we get on the left side, you have the combination of inhaled corticosteroid, LABA, and LAMA, which I thought was a good, like a last line of treatment to compare to PDE4 inhibitor. That they would also be they would also have severe COPD conditions as well. So the exposure measurement was Roflumilast cohort. The index date was defined as the first date of Roflumilast dispensing between May 2011 and June 2013, with no Roflumilast prescription in the past 1 year. And the control cohort was the combination of ICS plus LABA and LAMA. And the index date was defined as the first date of that combination dispensed on the same day within the May 2011 to June 2013 period, with no combination prescription that were filled out on the same day in the past 1 year. So this is kind of hard to explain, so I try to graph it out. So I would basically take that date as an index date if they started, if they had ICS prescription fill, LABA fill, and LAMA fill on the same date. So the problem I had, I would talk about this later on, but this would actually exclude patients who were already on, who could have used them concurrently but had different fill dates. And I initially thought that this definition by I ran the data with my eye, about like 500 rows, and I looked through them, and for the combination products, all three of them had same fill dates, most of them. So I decided that this was sufficient to define as the control, as the index date for the control cohort. But when I looked at the treatment regimen later on, then I think that there were some portion of control cohort that we're missing because we're not accounting for people who have different fill dates for these combination of products. And the identification of medication. So I identified 7 classes of respiratory drugs, either because of identification for exposure status or as covariate. And I used combined resources for identifying these medications. So which drug product goes under which class. So I used GOLD guideline and HEDIS list for pharmacotherapy management of COPD and asthma. I also refer to pharmacotherapy by DePiro and clinical pharmacology and micromedics. The outcome measurement was, so my index date was the first hospitalization for which I took as the primary diagnosis at discharge for either acute MI or ischemic stroke or arrhythmia. So I looked at it as a composite variable. So later on, I will try to do it as separate outcome as well. But for now, I've looked at the outcome as a composite variable. And then patients were followed up until first date of outcome. So first hospitalization for either of these events, or disenrollment or medication discontinuation, and which was defined as having a gap in the prescription fills for more than half of the previous days of supply, or having no more fills occurring afterwards, then I would take the last day of fill end, which was calculated as day of fill date of the fill date, and plus days of supply, or the end of study period, whichever came first. So the covariates I measured were demographics, such as age. I looked at that as a categorical variable with intervals of 10. And gender, I looked at region, which was defined as 5 categories per Truven database. And year of index date, which was 2011, 2012, or 2013. And baseline exacerbation frequency. And setting of exacerbation, and baseline resource utilization, which I looked at number of hospitalizations or outpatient visits or ER visits. And baseline comorbidities and baseline respiratory medication use. And I also, from the medication use table, I also created treatment regimen table, and I excluded SABA and systemic corticosteroid from the treatment regimen. And I pulled out the top 7 categories of the treatment regimen and pulled the others into other category. And then I also looked at the baseline frequency of hospitalization due to acute MI, ischemic stroke, or arrhythmia. So these are basically my outcomes, whether they experienced outcomes at baseline. So for statistical analysis, I used survival analysis, and patients were followed until outcome event or disenrollment or medication discontinuation or end of study period, whichever came first. And Kaplan-Meier curves were generated, and equality of the 2 groups were tested by using log rank test. Cox proportional hazards model was used to assess differences in the rate of event during person time exposed to Roflumilast versus person time unexposed to Roflumilast, which was actually exposed to the control medication. So the result of building the study cohort, I grabbed all the people who initiated on Roflumilast or the control medication, the combination, between May 2011 and June 2013. So that gave me around 74,000 patients. And I excluded those with no COPD diagnosis during baseline and no 1-year continuous enrollment during baseline, and those who are aged under 40, and those that Truven does not capture drug claims. So I ended up with the final study cohort being around 360,000 subjects.
360,000 or 36,000?
36,000, thank you. And these are the results. Demographics. So most of the covariates I looked at were significant. I mean, the 2 groups were significantly different from each other. We can see that the Roflumilast group we can see that Roflumilast group tends to be younger, so the control medication group tends to be older, and Roflumilast group had a higher proportion of subjects in the southern area. And I'm just going to point out a few pointers. So for exacerbation frequency, we can see that higher proportion of patients experience 0 exacerbation among the control cohort. So an exacerbation, you can kind of think it as relating to COPD severity. So the more exacerbations you experience, the more severe your COPD is. And the Roflumilast group tend to have more higher exacerbation frequency compared to the control cohort. And we can also see that the Roflumilast group had higher number of hospitalization, and they also had higher number of outpatient visits as well. So basically, the Roflumilast group were more sicker or severe patients. So these are CV events, so my outcomes during baseline period. Even though the statistical test says that that most of them are significant, I don't see much difference in the proportions when I look at the table. So I'm gonna skip to the next one. And the baseline comorbidities, most of these were not significant. And the only comorbidities that differed significantly between the two cohorts were not the only, but the ones I'm going to point out are the other lower respiratory diseases and sleep apnea. So this is the usage of a medication at baseline and the treatment regimen. And we can see that also the columns don't add up to 100%. It's among the, because they could have been duplicative counts. So we can see that the Roflumilast group utilized medications much more than the control cohort. For the treatment regimen, which I pulled up the 7 top treatment regimen and pull the others as others, we can see that at the baseline, the control cohort did not utilize any treatment were not on any treatments during baseline, much more higher proportion of them. And Roflumilast group utilized the regimen of SAMA and LAMA and ICS much more, and added to that LAMA, so those highlighted at the bottom. But if you see the blue box highlighted there, that's actually our control cohort treatment regimen, the ICS plus LAVA and LAMA. So we can see that still quite a lot of people in the control cohort even utilize those treatment regimen in the baseline. So I don't know whether they were using that concurrently or not concurrently, but there is a high chance that they were on the regimen even at the baselines by my definition of control cohort, that I was not able to sort out all the exclude all the patients who are using that during the baseline period. So this is a hazard ratio of cardiovascular events. So the crude hazard ratio of cardiovascular events for Roflumilast versus the control group was 0.99. It was not significant. And so the model building part is pending. Instead, for now, I just put in all the covariates into the model to adjust for all the covariates. And the adjusted hazard ratio was 1.06, which was still not significant. So the value itself shows that there might be a slightly higher increase, but not significantly for the Roflumilast group. And when I tested for the proportional hazard assumption, it was not violated using the global test, using Schoenfeld residual. So this is the Kaplan-Meier curve which looks like they're overlapping quite a lot, but the log rank test p-value was 0.01, and that indicates that the two groups are not equal. Okay, so this is my tentative conclusion. The Roflumilast users were, this is actually wrong, younger and sicker, more resource utilization and more exacerbations, and utilized more medication compared to the comparator cohort. When adjusted for every covariate, Roflumilast was not significantly associated with risk of cardiovascular events. So the limitations of this analysis was, I think the main one was my definition of control cohort that does not include patients who are on all three medications concurrently, but with different fill dates. And that would actually include all the patients who are not initiators of the treatment, but are continuous users as well. I also included subjects who experienced outcomes during baseline period. So these subjects could be prone to more risk of further CV events or systematically different. And the medication discontinuation date that I used was very conservative. So a lot of cases when I looked through the eye, got their refills earlier for 1 month, and then the next time they would fill it much later. But then in this analysis, they would be censored. So the future steps was to finish model selection, and then I'm going to do sensitivity analysis excluding patients who actually used the combination regimen during baseline for both cohorts, so that we can rule out the fact that we are including some patients who did not initiate the combination products. And I'm also going to do a sensitivity analysis by excluding subjects who experienced outcomes during baseline. And I will aim to re-identify control group by including patients who get fills on different dates but are concurrent users of the combination regimen, using the overlap in the days fill. And finally, I would also want to match the Roflumilast control groups on age, gender, and COPD severity. And I would like to acknowledge Todd, Patrick, and Shruti. Thank you.
Thank you, Inyoung.
Thank you.